Order, order. Good afternoon and welcome to the Women and Equalities Select Committee. Today we are holding our second evidence session on menstrual and reproductive health conditions among girls and young women. And it is part of our set of inquiries looking at young women and girls' menstrual health. And today we've got a fantastic panel in front of us. We've got Dr Aziza Sesay, GP and Women's Health Advocate, Dr Tori Ford, Founder and Executive Director of Medical Her Story, Chella Quint, OBE, Founder of Period Positive and author, Kerry Wolstenholme, RSHE Specialist and author, and Dr Nighat Arif, GP and Women's Health Broadcaster. Welcome to you all, and it is so fantastic that our committee is going to be gaining from your experience and expertise today. So my first question, Aziza and Nighat, come to you first. To what extent is challenging stigma and taboos around periods key to improving girls' and young women's menstrual health and well-being? I know that both of you do this in a multitude of different ways, using different platforms from television to online. But how important is it that we challenge that stigma? Aziza, I'll come to you first.
Okay, of course. So, hello everyone. Before I start, just to test the waters here, I have a little prop with me. Can I ask all of you if you wouldn't mind to say this out loud?
Vagina.
Vulva. So you said vagina, and that's the thing. So a lot of us were brought up to believe that it was vagina, and I think it's only this year in July that they've included vulva in the document. And that's the reason. We didn't have vulva there, but this is actually a vulva, and this is the external genital anatomy, female genital anatomy. The reason I always start with that, and I have everyone saying it, is because there's so much shame and stigma around it to this day. I'm wearing a t-shirt because I started a not-for-profit, I got you one actually.
I'll see
I brought it.
What's it say?
I'm wearing a t-shirt that says...
They are not bad words.
Yes, and at the back it says...
Vagina, vulva, clitoris.
Clitoris, yes. There's a song that we're campaigning for.
That sounds catchy. That sounds like it could be a song.
It is a song.
Wow,
it
you
literally
don't
is
say.
a song. I promise.
I bet it'll get to Christmas number one.
There is a song that's out right now, and we're campaigning for it to be Christmas number one. But the whole point is, genuinely, the whole point is, even when I walked in today and I was wearing this t-shirt, the guard said, please make sure that you keep your blazer on. Why? Because they still deem it as inappropriate, as bad words, as something that we should hush-hush about, as taboo. And that, unfortunately, is the reason where I often say that there are many women who are suffering in silence and who are literally dying of embarrassment. They do not come forward about their problems because they're embarrassed. I've had a patient who was ashamed. She was elderly. She had a massive vulval lump. You couldn't miss it. And she didn't come forward because she was embarrassed. And the only reason she came forward was because she was in excruciating pain. Excruciating pain. Took one look, I knew it was cancer. She has stage 4 vulval cancer, and that's not an isolated story. This is something that happens quite often. We need to break the taboo quite young, because really it's passed on intergenerationally. We're not born with the shame, we learn it. Head, shoulders, knees and toes, and vagina, and vulva, and clitoris, yes, those, they are not bad words. Often we say head, we say shoulder, and when we use euphemism, that perpetuates the negative narrative. I had someone say to me, oh, you know what, you've empowered me to teach my son to say penis instead of ding dong. And I was waiting for you guys to laugh. I'm joking. And he said to her immediately, thanks, Mom. So what's the real name for my elbow? Right? So why don't we normalize the word? Similarly with periods. And just the last point, because I know Nighat has a lot to say as well. I don't want to steal all the conversation, but when we teach our children the correct terminology, we are protecting them. We give them that body confidence, we remove the shame, and then they're able to describe the areas in which they're experiencing symptoms. My daughter is 7, and we're selling little crochet pocket vulvas, and I have a vulval anatomy card, and I printed it out, and I was so excited, I showed it to her, and she's like, Mommy, why didn't you label the perineum? She can say to me, Mommy, I am having pain in my left outer labia. I have patients saying to me, Doctor, I'm having a lump in my vagina, when they mean vulva. And finally, it's to protect them from sexual predators. We do know that evidence shows that sexual predators often avoid children who use the correct terminology because then they know that this child has been taught about body safety and autonomy and anatomy and know that they will say if someone is touching them. There's a young girl who was being molested by her uncle, and her mom taught her to say cookie. So she tried to tell her mom, he keeps playing with my cookie. He keeps touching my cookie. And it took a long time for her mom to understand what she meant. When they use the correct terminology, there's no confusion. And that's why we need to remove the taboo from the genital anatomical names.
Thank you. Nighat, I should declare that we've worked together before.
We have?
Yes.
We have on some incredible campaigns, can I just say that for the record?
And I'm a big fan of your work, but I just wanted to ask about how important it is for really young girls and how you break that stigma at a young age.
I mean, Aziza has just said all the key points. I think the first thing we need to come back to is 50% of the population have external female genitalia. And if you don't know the words for that, that leaves you at a huge disadvantage. The shame and the stigma runs deep. It runs against or sort of across genders, so even females themselves. It runs across language as well. It runs across in regards to health. It runs through faith groups. It runs through marginalized communities as well. So if we look at just the language that you use, the words are, in Punjabi, we actually don't have a word for vagina, we don't have a word for vulva, we don't have a word for posterior fourchette, the clitoris, the labia. So actually, how do these communities go and actually speak to a healthcare professional? So we know that there is birth trauma, a natural process that happens, but currently as it stands in the UK, Black and Asian women are 6 times more likely to have perineal tears and then seek help later on. And that is, I'm part of that statistics. I've had a 3rd degree tear, I've had 3 children, and you're left with these long-term birth injuries. We are very open to talking about things like caesarean section being a birth injury, but actually when it comes to the perineum, we don't really have that much support available, and there is lots of education that needs to be done around that. And then it actually translates into how that topic of conversation is discussed on social media. That's becoming more widened. Healthcare professionals like myself and Dr Aziza, we're actually censored a lot because we're using medical terminology, but the word penis is not censored. But I think that also is something that needs to be worked upon, and it is. So like Dr Aziza, I also have a vulva model that I use, and a lot of my content, firstly, I get told that I'm besharam. Besharam is translated as shameful in my community. And I think a long time ago, I realized that the single thing that stops any advancement is to say, but we've always called it a cookie, a flower, a down there. So progress isn't able to happen. Vulval cancer happens, vaginal cancer happens, cervical cancer takes lives and has taken lives. But actually, if you think about it, a lot of women don't realise that vulval cancer happens, and it's something that they need to look out for in the signs or symptoms, or even understand the red flags. I also think that when it comes to knowing your anatomy, then you're empowered to actually make access for yourself so much easier, because you're able to say, as access is getting harder and harder in the NHS, we have forms that you have to fill out in order to sort of get access to the GP. But also, if you're able to say what bit of the anatomy is affecting you, then we know that we can navigate healthcare within the system much faster and easier. My final point would be that when it comes to understanding anatomy and the stigma and taboo, it needs to become part of our lexicon widened out. So you can use the right anatomy, and men need to be part of it. To be able to say vulva is not something that is an onerous for women. I'm a mother to 3 boys, so my boys know their anatomy. I'm the only woman in the house in my immediate family, so they need to know what's happened to mum. So when they inevitably, and I joke that sometimes that they put me in a home, that mum's vaginal estrogen goes with her, because they know exactly what that does in regards to helping with, say, vaginal atrophy, genitourinary syndrome of the menopause, because our genital anatomy follows our whole life cycle. It's not just for the young. Yes, it's so important to educate the young, and there's work being done, but it's throughout our fertility years, our perimenopausal years, menopausal years, postmenopause, and beyond.
Thank you. I'm just going to come back with a follow-up on shadow banning, and then I'll pass to Kevin for a supplementary, and then to Rachel. Nighat, you talked about getting shadow banned or cancelled on social media. What does that do? Can you talk through how that happens, and have you had any contact with social media companies in how we tackle that and stop it happening?
So it comes in different forms. It could be the fact that if I have a model, my content will be taken down, because actually there's users on the platform who will say, I'm visibly a Muslim woman who wears a hijab, who will say, this is actually something that's against our faith group, this is forbidden, this is haram, this shouldn't be seen. And so they'll report me for breaking community guidelines. So that's one way that the platforms will take my content down. Or if I write the word vagina, then that gets screened by the content, sort of the algorithm, and it will take my content down as well. So it's usually users as well as the algorithm itself. And that means that I'll get a notification. So I've had my TikTok account taken down 3 times.
Wow.
I've had my YouTube account blocked twice, and I've had to take that up. And I've had LinkedIn take down a video of mine where I was explaining the role of low-dose topical vaginal estrogen with a model, saying I'm promoting a product. And that isn't a promotion product. I made it very clear. It's because I'm talking about something that's available in the NHS on prescription. So it's an educational post. And the same with Meta on Instagram as well. Myself and Dr Aziza, we're part of the YouTube Health Content Creators, as well as the TikTok Creator Academy as well. And there's lots of dialogue that's happening. So I've been able to reinstate, on my personal account, I've been able to reinstate that. But that means that if I look at other accounts who aren't making that content, the growth isn't there. So I would say that that's not getting to the wider audience. It's still hampering a lot of our content. If I look at male content creators who are probably making exactly the same content as me, and I've realized are probably self-censoring. So then that comes to the point, as a creator, do you self-censor those words? Again, making it more shameful and taboo. But I find that their content then is growing, although they've said exactly the same thing as I have without using the word vagina or vulva. But that's not what I want as an educator, as a clinician, as someone who works in the NHS, because I don't want to self-censor, because these are medical accurate terminology.
Absolutely. Aziza, have you had... So, like, I can't get my head round the idea that TikTok will and YouTube already know that you are doctors and this is the message that you're trying to get out. And why is it that they would take down any of your content or any of your personal sites? Why would they do that? Especially since they know that you are working with them to create this. Aziza, have you had any negative experiences, but also has there been any positive change in how they're actually going to help with this? Because, like, as we've seen, particularly for certain words like vulva or clitoris, like they just take it down, or it's banned, or it's not even always just taken down, it's pushed down further. Yes. So you're not going to get the growth and spread the message.
Yes, so I've had loads of people say to me, Aziza, have you posted anything lately? I don't see your content. So that's what shadow banning is. They just make it so that it's not visible. Even if people are sharing it as often as possible, it won't be visible. Recently, I did a post with the Eve Appeal where we were showing how to check your vulva, because many women don't know how to check their vulva, and I used this. And then I didn't know, but someone flagged to me that on my page, when this video is clicked on with this, it has a sensitivity cover on it. And then when you click on the sensitivity cover and you ask why, it says because people will find this upsetting. So that's over. It just showed this because of this image, that's why. And also because I said the word vulva and I spelt it correctly, because again, we don't want to self-censor, because that just perpetuates the narrative. I have worked with YouTube and I've had the discussion with them about this as well. And the thing is, unless it's an individual person who's looking at it, they automatically assume that if you are going to be talking around these areas, and usually women's body, because there's a hypersexualization of our bodies, is automatically deemed as pornographic and inappropriate content. However, if it's sexy, and I have to admit this, if you're, being provocative, that doesn't seem to get censored. So it's almost like a pick and choose thing, and genuinely this is how it feels. But yeah, no, I've spoken and I've worked with YouTube. There's also a campaign called Censorship, and they're looking into all of these banning. They've gathered evidence. I believe they put a white paper together, and there was, I think, a talk in Parliament with SAT recently. Again, a lot of us are seeing it, and And it's not because we are trying to make money. A lot of us healthcare professionals are putting this out there. So I'm going to share this story. I had someone who saw the video with the brown. Another thing I want to talk about is I used brown because you don't usually see the representation. My vulva is brown. And she saw one of my videos, and then she realized, oh, I need to pay attention to this. And so she checked her vulva, and actually she's now been diagnosed with lichen sclerosis. We know that there's a low chance, if it's not treated properly, that it could progress to vulval cancer, so hopefully that won't be the case for her. That's the story about these videos. These videos are life-saving, but we can't show them. Similarly, if we're trying to show what happens during cervical screening, it's the same. It's all seen as too much or explicit or inappropriate, and we're having to fight. It's like an upward struggle, and unless it doesn't make any sense to me. It boggles the mind that they're able to create all these incredible AI, yet they can't get the tech that can differentiate between pornographic, inappropriate content and scientific, accurate, life-saving content.
But also just from content creators that they actually already work with. Like, surely that should be pretty simple to do. I'm not a tech wizard, but if I think like Nighat or Aziza is going to be posting something, I'm going to go, this is not pornographic. Like, you don't have to take this down. It's kind of common sense. You've both mentioned vulva cancer a couple of times now, and you said that there were some simple red flags. I think it would be like a missed opportunity if we don't say what those red flags are now. Can you do it for us?
Of course. So firstly, I would say look at the skin really importantly. If you see any red patches that are new or different to you, so know you're normal. If there's any lumps or bumps that have changed, particularly if they're evolving pretty quickly within the last 2 weeks, any lymph nodes in the groin as well. Any lesion that's bleeding, so any heavy discharge from the vagina. So the vagina is the canal, but also look at the vaginal opening as well. If there's any sores that haven't got better over time and you've tried different ways to manage that. Also, if there's any loss of architecture, so that's the other sign that we're looking for. That could be the clitoral hood, loss of the labia minora, so that's the inner lips as well, or labia majora as well. And any sort of gross or ingrown sort of bumps within the actual pubic area in themselves that are just persistent and not going away. We always think about pain. We say pain, irritation, and also if there's any pain at night pain or itching, that is also sometimes a red flag as well, because that's disturbing your sleep, and that needs to be checked out.
Just to quickly say, sorry, because some people don't even know how to check, so literally make sure that you wash your hands and get a mirror, put it in between your legs. So either you're lying in bed and you get your legs wide, or you can squat down, or one leg perched up on the toilet. People don't even know this basic thing because we don't get taught it and we're seen as inappropriate. Just really quickly, because we kept saying vulva, I also want to mention vaginal cancer. The hashtag vaginal cancer was hidden because it was deemed as inappropriate. And there was a woman who was sharing her story about vaginal cancer. How is she supposed to feel if her cancer is being censored and being told it's inappropriate? It almost feels like shame on you for having that, So
And finally, Sarah, can I just come back just through the examination, because I just want to add, one of the things I'm really trying to get women and girls and also clinicians to do is please examine standing up. Because I get women both going, I feel like the world is between my legs. And what they're talking about is a prolapse, but they don't have the word for prolapse. And actually, if you examine a woman lying down, you won't see it because gravity's pushed it back up again. But other things like men who have hernias, we examine them lying down and we examine them standing up. Why? Because when they cough and against gravity, their hernia comes out. So the same thing as with women as well. If you're, and Aziza said that really well, squat. That is a really important. So put a mirror between, cough, and see if there's anything that's coming through in the vaginal opening or in the back passage, because yes, rectal prolapses do happen to women as well.
Thank you. I didn't want to miss the opportunity, since we've talked about it quite a few times. You said there were clear red flags. We should know what they are. Kevin, and then to Rachel. Rachel's got some questions for Tori and Chella.
Thank you, Chair.
So sorry, I had something to briefly add about stigma, because we look at stigma in a slightly unique way. Do you mind if I share that quickly before we move on? Thank you. So we know stigma is harmful, and we see tackling stigma and taboo as an essential first step, because in our experience it opens the door to learning, but sometimes people see it as the end point, and I not anybody on this panel, but sometimes we see situations where if you don't pair taboo breaking with menstrual literacy to back it up, the information has nowhere to go. So people might learn something, but it will stay with them. So creating a culture of taboo breaking to avoid leaving a vacuum is one of our aims, because we've already seen that vacuum filled by sometimes opportunistic companies maybe selling products that are not necessarily regulated, or tools that haven't been vetted, which happened before, and sort of ignorance and shame were sort of used to sort of, you know, benefit from that shame. So it's heartening that the new openness around menstruation has reached the highest level of government, and I'm really grateful to be an excellent company today. And I wanted to share that we are starting to use the term institutional menstrual shame. And by this we mean that menstrual stigma is so baked into the institutions that make up our society, and also everyday routines, that even when an enthusiastic leader or youth group or external project makes progress, that progress can vanish when the staff move on or the funding ends. So we've been designing and testing frameworks that I'll talk about in a bit that address that, but I sort of wanted to share this idea of all of this great work individually needs support holistically, so that it's not the final step. But it's wonderful that this session started with asking about stigma.
Thank you very much, Stella. I
Thank
think
you.
Rachel will have some more questions about that and the period positive pledge as well. Kevin.
Thank you, Chair. Before I was doing this job, I was a nurse, so I'm very tuned into the fact that actually even within the clinical professions, lots of euphemisms are used, and we've had lots of battles down the years trying to de-euphemize what we do. Cutesy euphemisms like passing water instead of urination, but also sometimes dressing things up very, very scientifically sounding, like micturition, which frankly most of the public have no idea what that means, but it helps clinicians somehow distance themselves. While you've been doing this work, have you had some sort of, is there cultural resistance still in the clinical professions that you've encountered? Is that a problem? And also, how do you determine which are the right words, the most useful words to have a common understanding of? For instance, you know, many people still use vagina instead of vulva. I can see the technical reason for that. But how do you ensure that actually we're not over-medicalising? We're using language that everyone can use?
For me, when it comes to producing my content online, there is that cultural barrier that I have, because I'm trying to break that taboo within my own community. So I'm actually addressing everybody and my patients. Where I practice, a lot of my patients are from Black and Asian communities. I'm Pakistani. I speak Punjabi in different languages. Because we don't have those words, I see the limitations and the problems that could have been prevented had they just been picked up early enough. So I go back to what are the common medical language sort of terms that patients would understand quite well. And I think you highlighted that really well. So we know that some medical words like micturition actually doesn't mean that much. The same with as a patella would mean nothing, but you know a knee is still medically accurate. I think when it comes to female genitalia, as clinicians who are working with patients and also the general public, who have started using these terminology words within their lexicon anyway. The other one that I'm really pleased about is a lot of my Pakistani ladies will come in and say urethra, and I'm like, that's amazing. And that's because they've seen me say it. So it's almost like, you know, it's that pattern of, well, this is the actual word from where I passed urine from. Okay, so my urethral opening is sore. Actually, my vaginal opening is sore, because the vagina is the canal itself. And making those sort of distinctions comes because we are trying to be as clear as possible to make sure that patter of language goes through. The pushback is there. I get a lot of trolling. I get a lot of my content taken down. It's sometimes seen within my community as not the done thing, but I think I'm slightly maverick in that respect, because I know as a clinician who works very closely with my community, and I have a lot of respect for my communities, and I understand why there are cultural barriers that are there. They are always grateful when those barriers are broken down, because the education gets through. So now I get a lot of men from my communities, fathers, brothers, who say, my wife went for the treatment because she saw your content. So I think it's just knuckling down and ploughing and being sort of present, I would say, and being consistent.
And are you getting any pushback from clinical colleagues at all, or do we think that's...
So at the start, I think there's a lot of cynicism within healthcare professionals. I've been on social media platform for 3 years. And before that, I was your average GP working in just a GP, I like to say, not doing anything fancy or clever. And then I just thought, actually, this is something that my colleagues could learn from. The pandemic was a turning point for me for using social media. There was some cynicism from colleagues, but now I think that because colleagues are seeing that their patients are on these social media platforms, so their patients are coming in knowing the information, and I think it's a missed opportunity as healthcare professionals if you're not on that platform, because you are missing a lot of the information that the patient's getting, whether that's the accurate information from healthcare content creators like us, or whether that's misinformation. And the misinformation, I know we're going to come on to later on, but that is rife. So as healthcare professionals who are meant to be leaders in healthcare, we have to do our due diligence and know what our patient is consuming, because they are going to come through the door asking for that. Finally, healthcare professionals, it's so busy, it's an ever-changing world, and all of us have our own area of expertise. I would say I'm not the best of everything. So the way I learn is following very, very excellent clinicians, because I'm like, oh, and we're like magpies, we're learning from each other when there is a difficulty to keep updated all the time. So that's where my content from healthcare providers, they're grateful, because they're like, oh, I didn't know that the guidelines had been updated for this.
Thank you. Thanks, Kevin. I'm just going to bring in Rachel, if that's all right. Rachel.
Thank you. My first one is to you, Tori. Is it okay if I call you Tori? Yeah. Your approach includes publishing lived experience narratives, holding storytelling events and those sorts of things. Why did you choose that approach? And is there evidence that it's effective in normalising those conversations about menstrual well-being?
Definitely. First off, just to say, I've never been in a room before where we've said vulva so much. So thank you so much. Usually I'm the first to say it, so I'm amongst royalty. But yeah, Medical Her Story began with my own story. So I've lived with chronic vulval pain for over 10 years now, starting when I was a teenager, and trying to go to different medical professionals and share what was going on in my life, trying to make sense of it. And of course, at that age, you know, coming into your body, coming into what it means to be a young woman, a young person, there's a lot of complexity in that. And I faced a lot of dismissal that, you know, we've been reading about in a lot of these reports of saying things like, oh, well, just change the color of your underwear, wear white underwear, that'll change all of your pain. Or maybe take some time off school. Have you ever tried having a glass of wine and relaxing? Really sort of dismissive advice that really sticks with you. Or I remember one of my healthcare professionals saying, you know, oh, well, some people get coughs. You know, some people get coughs repetitively. Some people are just more prone to chronic vulval pain. It's kind of like that equation of something that for me was rooted in a lot of shame and stigma, like we've been talking about today. At that time, I didn't really understand the words like vulva. There was so much embarrassment that made it really hard to speak out. And looking online, this wasn't really something, 10 plus years ago that was talked about a lot online. So I actually started sharing my own story with some of my friends and community members, and they said, you know, Tori, you've been through so much, it sounds like fiction, you should write it. And I thought, who wants to be the face of vulval pain? That's taboo, that's embarrassing, that's shameful, and here I am. So I ended up writing this story for actually my school newspaper, and it went on to make the front page. And I was really, really horrified of what have I done? You know, I'm talking here about my body, about my pain, about the complexity of what it's like to be navigating a health system and feeling not listened to. Are people going to say, you know, this is gross, this is shameful, this is unladylike or unprofessional? But instead, I heard so many people saying, I have a story to share. Friends that had ovarian cancer at 18 years old, being told, don't worry, you're gonna get through it. It's the female equivalent of testicular cancer. Sort of, the phrasing, these subtleties in the ways that people were talking about their bodies, or, going to doctors repeatedly with chronic menstrual pain and just being told that's normal, that's natural, we all deal with that. So people said, we have these stories, we want to share them. What can we do? And that's how Medical Her Story was born. So today we've shared over 40 different stories internationally relating to different topics, and we're working to eliminate sexism, shame, and stigma through those stories. And in terms of some of the impacts that we see, so I think we have a lot of evidence that shows how impactful stories are, especially when they're used alongside statistics. I'd say first off, we hear from individuals who share their stories about the impact on them. Often it's their first time speaking about these issues, putting them in writing. A lot of times we have people who start off with the process wanting to be anonymous in their story, and by the time that they've written it, they say, actually I want to put my name on that, and that's really powerful. We also know that there is a need for these stories to be shared. So in addition to having our written evidence, we've held over 50 storytelling events, and we've had over 2,500 participants. So there's a real need and desire to hear these stories. And we've done those on vulval health, we've done them on trans health and trans joy, Indigenous health, refugee and migrant health, and bringing people together in these spaces to share their stories is really impactful. And then just some of our own internal data. So from these events, over 80% of participants reported decreased feelings of isolation in navigating their own health experiences. As we talked about, I think one of the main things shame and stigma does is isolate you and makes you feel alone. 90% reported feeling more educated, empowered, and aware of patient experiences. And we have similar data both from storytellers and the audience. So we've seen this in many different areas of how hearing these stories, I think, sticks with you. And as we've even hearing today, when you're able to illustrate something with a real case, I think it has power to it.
Do you think our NHS could learn some lessons from your approach?
Yeah, I think so. I was doing a quick look actually today on the NHS web pages. And I reached out to some of my colleagues and said, I have an idea. I think it would be amazing if when you went to the NHS sites, there were stories. There were stories of experiences. What does ideal care look like? What is it like at the end of for me, the 10-year journey where now I have an absolutely amazing sexual health doctor, and sort of all the details that have made the care so wonderful and so helpful and so empowering, versus all those experiences where maybe a doctor at the time isn't thinking through a comment like, I'm going to reassure them, it's normal, it's natural, it's common, it's just like having a cold. And sort of take those seconds to pause and think about it. And I think, too, something Medical Her Story does well, and that we could see more in the NHS, is co-production, really bringing patients in for having seats at the table. So in addition to the work that we do within storytelling, we also share we do teaching in medical schools, and we also do patient advocacy workshops. So recognizing you're never taught how to go to the doctor, we thought that was quite odd. Yeah. So we do a lot of that work now that we would love to collaborate more with the NHS on, but also, co-design and co-production in websites and public-facing materials, I think could be extremely impactful. And I think there's so many patients and patient groups, many on this panel, who'd be happy to do some of that work.
That's great, thank you. I'm going to come to you, Chella, now to talk about your period positive pledge. What aspects of the pledge do you think are most important in challenging stigma and taboos?
Thank you. So I should start by saying the period positive pledge is based on the phrase period positive, and when I coined it, it didn't mean that all periods are wonderful. Many periods are a pain in the uterus, but it means that talking openly about periods and the whole menstrual span is a positive act. And then the definition has become more and more detailed over time. So over the years, as individuals and organizations have contributed to the project through co-design and participatory partnerships, it's remained a grassroots idea that's become more and more tangible. So the key negative message that we challenge is the idea that a good menstruator is an invisible one, someone who never leaks and maybe never even mentions their period. So advertising has almost entirely, for the whole history of menstrual product advertising, portrayed leaks as catastrophic and implied that buying the right product, especially their product, would improve everything. And menstrual researchers have started calling this the menstrual concealment imperative, and pointing out that means people sometimes have to, borrowing language from critical race theory, to pass as a non-menstruator. So saying that the norm is not having periods, even though obviously we know that's not the case. So the period positive pledge itself grew out, and here it is. It's sort of designed to look memorable. And there's a kid's version that the editors of my children's book helped me develop so that it's in child-friendly language. And that's available online for people to use freely. But it came out of my master's research. So my students were testing taboo-breaking lesson resources in sort of an action research learning lab when I was teaching drama and head of PSHE. And in my spare time, I was doing stand-up comedy about periods. So I know that's very stereotypical about, female comedians, they just talk about periods. That's absolutely not true, and we are all very funny. But actually also I happened to be talking about periods, which was a bit awkward when it came to the stereotype, but really, really fun. Because at the time, 2005, when I started talking about it, not a lot of people were doing the whole thing. Like, people talked about other stuff too. And so turning those into lesson plans was a lot of fun for me, but it didn't really matter if it was fun for me. It was, I wasn't doing 6 shows a day in the classroom. It mattered that kids needed something better than a leaflet with very sad girls worried about puberty. And so this is actually one of the things we did. We looked at stains TM, a removable stain you can wear on your clothing, to create something that we called leak chic as a joke. But when I brought it into the classroom, young people just took it away. They became executives in media and marketing firms, and they created, using media language, a product. They created an ad spread for Vogue. One of the kids said Le Stain, because she knew that fashion was French. The joke we decided was too naughty was clot couture. However, clots are a part of menstruation, and we shouldn't censor ourselves. So, thank you. So yeah, in the spirit of not censoring, we decided to tone it down to leak chic, but kids learned advertising language that they had been influenced by, and said they no longer wanted to be influenced, they wanted to be informed. So they wanted unbranded products in the classroom. And they had 3 demands. It was co-design project. They had outputs that they were recommending as well, and their outputs were: tell us everything, show us who we can trust, and include everyone. And that led to 3 things: the period positive pledge, and 2 other framework tools, which were an award symbol, so they could see which teachers and eventually schools and cities they could trust. And the symbol's just like an open mouth smiling blood droplet. So it's open mouth because it moved on from a little simple smile, because they said it wasn't always happy. It was about talking and also about laughing, using joy to challenge shame, and sometimes even shouting when they were angry. And the third was a curriculum guide, sort of like a program of study, just like any national curriculum subject has a program of study. So the pledge is meant to be taken as a whole. It helps people join the conversation now if they're new to. It's sort of like if you're starting a new TV show, but you're jumping in at the middle, and the episode starts with previously on. So this is sort of like a previously on menstrual activism and advocacy. So the lessons that we've learned from working with partners over the years focus on challenging the things that have become so normalized that we don't often question them. The we've always done it this way problem that you mentioned earlier. So like only teaching girls, or relying on corporate lesson packs. So some key pledges focus on language, avoiding euphemisms and outdated industry terms like sanitary protection or feminine hygiene, and instead using accurate words like menstruation, menarche, and menopause, which everyone is allowed to use. People sometimes don't feel they're allowed, or that those are medical terms or scientific terms. But, medical professionals and scientists have periods, and those terms should be for everyone.
Chala, what progress have you seen in the adoption of the pledge?
I've got bullet points.
Sorry.
No, thank you. That's great. I appreciate you asking that. Let's see. So we've now seen the pledge used at every level, from individual homes to towns and cities. So some of the pledges focus on avoiding corporate over-influence. And so places where people have wanted to make their own resources or challenge that sort of, you've got to use this product from this company at this expensive price that's advertised at this level, and here's some bits and pieces for you. They rejected that. And so they reached out so in schools where we piloted it, pupils and staff have used the pledge really creatively. One school had pupil champions use it as the basis for a youth voice project to redesign the toilet block, which was about to be renovated. So they requested individual cubicles with floor-to-ceiling doors and sinks and bins inside. And one of the reasons they cited was so you could wash your hands if you got blood on them. Another reason was they wanted to be able to rinse a menstrual cup without having to leave the stall, or use an internal menstrual product, without worrying about tracking blood onto the doors and things. And the same school used the pledge in a different school used the pledge in a whole school conversation about toilet access, which led to an audit. And the audit was based on work originally developed by Shirley Prendergast, who was a researcher in Cambridge, who published the audit in 1994. When we tried it again as part of the master's research in 2013, we got the same result. That led to a new policy where the head teachers made it explicit that toilet access was allowed at all times and that it shouldn't be linked to discipline. And it seemed to have become this tacit rule, even though it was never official policy. And so this was easily undone. So 2 more schools adopted it later, and the pledge became something that they used for a planning tool for designing cross-curricular education materials. So kids and teachers were working together to create their own lesson ideas that were, as creative as the period stain one, but from their own ideas and using lots of different school subjects to support it, which meant that more topics could be covered from the curriculum model and more staff could be justified to be receiving training. I can talk about that afterward, but I wanted to mention that beyond schools, one primary care trust has used the pledge to change language in posters and policy documents that are displayed around and used for their own staff. And staff involved in the Free Products Bill guidance told me that their advice on avoiding euphemisms in the free product guidance came directly from the pledge. And 2 parents in different parts of the country got in touch by email at completely different times to say that they'd put the pledge up at home or wanted to put the pledge up at home, and could I send them a copy, because they wanted to show their own kids that they wanted to be an open, period positive household. And finally, at city level, councils in Sheffield, Brighton, Swansea, and most recently Frome have all drawn on the pledge and the period positive award to build in strategies that are ongoing.
Thank you. I've just got one more question. I'm loving the stain. I might call it TM. I might, if I was a purist, call it la stain. But
le vagin. Sorry, it all went into French for a minute.
And the leak chic, and obviously that's one of the negative media messages that you're trying to combat. That sort of a good period is only an invisible one. But are there any other negative media messages that you've been trying to combat?
So many. I got a TED Talk. You guys should watch it. It's old, but the second half is very accurate. The idea that periods being commodified is a problem. Periods being something that happens to you is a problem. periods shouldn't be portrayed as something that happens to you. They should be portrayed as just one small part of something very interesting that bodies can do. And other pubertal stories. There's a great piece of research from New Zealand in 2012 that talks about how all the male puberty changes are talked about as being really positive and additive, and all the female-bodied ones are, portrayed as sort of negative. Even the pre-2019 RSHE guidance document talked about coping with periods, and I was one of the people that requested that it be changed and that 3 sentences be moved to 6 sentences. But in terms of menstrual product advertising, there are 4 types of menstrual literacy, and I think we only learn about 2, and the other 2 are really essential for dealing with those negative messages from corporate media. Body literacy, product literacy, lots of us already do that, know that, could teach it in a pinch based on what we've learned, but media literacy and cultural literacy are equally important, and they're completely missed most of the time. Kids need to know that in all cultures, all over history, all through time, people have thought blood was powerful, menstrual blood most powerful, and power doesn't have to be good and doesn't have to be bad. It depends on how it's interpreted, sometimes after the fact. But also, media literacy. 1926 is like my favorite ad to hate about menstrual product advertising. It talks about a great hygienic handicap and the women of tomorrow, and posits disposable menstrual products as this aspirational concept. And yes, they helped a lot of people to not be tied to using reusables in a time where we didn't have washer dryer combos in our kitchens. But the result is that we have 100+ years of this echo of media negativity, and if we don't challenge those messages or instill in people the ability to be literate about those messages, specifically those words: whisper, secret, discreet, end, accident, panic. A menstrual product, leaks. Okay, you have to wash that pair of jeans, but it shouldn't be sort of, social shame that you remember from school onward.
Thank you.
Thank you. And it is interesting that link between comedy and challenging those misconceptions. And I think that is often the case. But thank you. I'll hand back to you, Chair.
Thank you very much. We're still on our first section. We've probably got another 6 sections to go. Yeah. So if we can try and keep some of the answers a little bit shorter. And if there's anything that you think actually is worth us looking at in more detail, please do send in as written evidence as well. But also this is partly our fault because we are finding this so fascinating. Yeah. And yes, Tori, it is lovely to be in a room where we can actually talk freely, and it is a special part of this committee. So thank you. Kerry, we haven't heard from you yet. Yeah. We are going to go on to a section which is about RSHE, specifically the curriculum. But I noticed that you were nodding at quite a lot of the storytelling and the other kind of ways of communicating information. Is there anything that you wanted to add on this?
Yeah, I think around stigma, I think you've also got to remember that the people that are being tasked to challenge the stigma also carry that stigma themselves. Yeah. So we need to go back and really change that. And as much as things like the guidance are helpful, and especially the new guidance, because it does say vulva, there's still a apprehension as what's okay, what's appropriate, this word age appropriate. There's nothing that confirms age appropriateness. And if we've got media taking down crochet vulvas, then teachers are then saying, is crochet vulva okay in the classroom? Is it not okay in the classroom? So explicit, honest, direct, clear information to those people reduces their stigmas, because it's been, I really love to see people own it, to go, this is what we think is age appropriate, there's your answer, there's your confidence, there's your clarity. I liken a lot of support and guidance in challenging the stigma to the technical challenge on the Great British Bake Off, where it gives you some information and then the rest you have to kind of piece it together yourself. And for people who are great at this, we'd just be like, no, that's fantastic, we could do this and that. But for somebody who's new, they'd be looking at it like, what exactly does it mean? How far can we go? What's too far? What's not? So for me, if you want to challenge that stigma, it really is like, just make everything clear, direct, obvious, clarify it, confirm it, stand behind it, give it to them.
Thank you.
Yeah.
I'm going to move on to Kim, but I think this kind of conversation is still going to continue as a bit of a thread. Mm-hmm. So, Kim.
Yeah, brilliant. Thank you so much, Chair. Goodness me, thank you so much. This has been amazing already. What a fantastic panel of brilliant, wonderful experts. I will confess, I think I am part of the problem, because I'm a very open person generally, but when it comes to these issues, I'm not very good, and I am guilty of talking about my bits, and I'm embarrassed that that's what I do, but I have to be honest that is the case. So this is so refreshing. I'm going to talk about communication. You're all amazing communicators, which is wonderful to hear. How well is the NHS communicating in this regard? And what does that look like in terms of content on NHS social media, the NHS website? If you could all maybe share a couple of fairly concise thoughts on that, sorry, Chair. But I also quite interested listening at the accents on the panel. I'm a northern woman, I'm a Yorkshire woman, and I'm getting a northern vibe from you, Kerry, over there. But I'm also getting other accents. And I wondered if you think there's anything around being British that is part of this problem around having these conversations, or are there similar issues in other countries? Are we not unique in that?
We're definitely not unique.
I don't know who wants to start with that. Shall we start? Kerry, I'll start.
Well, I would tell you what I see in the classroom with teachers, and I have done for 28 years of teaching RSHE, is teachers that are so keen to do this lesson, but then when it comes to saying the word, so they'll go, we're going to do about sex education, we're doing about body education, we're going to do about vaginas. And it's like whispered, and it's because it happened in our households. It's still there, and as much as you can go on TikTok and scroll, and it's not on TikTok because people are saying all this information and words and explicit stuff online, we are still not kind of become comfortable with the health aspect of that. So we just need some support in differentiating the two, of like inappropriateness and not inappropriate, okay to say, okay to do, okay to be. And in terms of the NHS stuff, and I think there's a real battle a lot of the NHS materials still look like a 1985 Word document. And when you're challenging that against like the content that people can create now online so easily, that looks great, looks like they've got a production team behind it. If you're a young person, where are you going to go? So we need to step up and get better at creating stuff that's quality. Like, we want to see some quality education.
Yeah. Brilliant.
I echo everything that. So I'm hoping I'll give you solutions on some of the things that we've been doing. So I'm a trustee at Wellbeing of Women. Aziza is also an ambassador for Wellbeing of Women, and we've been doing lots of work around just knowing what your normal is, because I think we've moved quite far away. So it was really refreshing when you said your bits, because actually that is really common, and actually it's because we don't know what is normal. How do you know that this period or silent period is okay, or this heavy period is okay? So we've done some really hard-hitting campaigns where we've worked with grassroots organisation. I co-founded the Health Collective with Professor Dame Leslie Regan, who's the ambassador for Women's Health Strategy as well. So we've done just a period. We've also done know your period as well, so knowing that, you know, clots aren't normal, pain, changing your period product every hour to half an hour isn't normal. And then also we've done a symptom checker as well, a period symptom tracker. So 60,000 period symptom trackers have been downloaded and used. At the end of it, you answer some questions and you get a form that says, this is not normal, please go and see your GP. I've actually had one of my patients come and see this, branding this letter in my practice saying, my periods are very heavy, I'm passing clots that are the size of my fist. My period doubles over so much into my life that I'm missing school and education. What are you going to do about it? And I was like, so happy that she'd used this and brought this along, because it assisted her and my conversation on what we can do further. Because patients might not know the diagnosis of fibroids, endometriosis, adenomyosis, PCOS, or PMDD, or perimenopause, but actually knowing that their body is changing at certain points is really great. Out of that, what we found is 62% of respondents did seek help and get a management plan. So simple things that we could do for the NHS, because I look at the NHS website profusely as a GP, and it is very much outdated. I think the other thing is that there's an arm, with the NHS team and the communications teams, I've been having discussions that those lived experiences of patients is really great. And I think also having like a symptom checker when it comes to the menstrual health from Wellbeing of Women, which is free, it's out there, would be a brilliant addition to the to the NHS website. So that modernizes it. Also, I think it'd be great to have links with content creators out there as well, so it can go to a video. It doesn't have to be mine. It could be all the brilliant, excellent content creators out there that says, this is what a normal period is. Actually, this is what endometriosis is. Because otherwise, you're looking at these stock websites which don't actually mean anything. But we know that the biggest trust that young people, all age groups, have is still within the NHS, thankfully. And so we know that there's already a buy-in because people trust that, and they'll bring that to the GP surgery. So the educational bit, I think we don't have to reinvent the wheel. We can just use what is already out there. And the other really quick win, which would be great, which I know we're going to come on to, is free menstrual products being available at like the GP surgery, at sexual health centres, at schools as well, so that we're not sort of thinking that you having periods is a problem, because we know that women bleed, men know women bleed, boys and girls know women bleed and girls bleed, but yet the shame of it and keeping that very, very quiet perpetuates the fact that help isn't sought.
Brilliant. Does anybody want to add anything to that? Yeah, shall I go for it?
Very quickly. So the resources need to be accurate and engaging in equal measure. I worked with the BBC Bite Size and Newsround teams in 2020 and 2021, and supporting their period-related content. The most popular segments were a quiz on the Bite Size resources and an animated bit. But the Newsround special did get nominated for an international Emmy. So the whole thing was engaging, and it had lots of different magazine-style segments. We also recommend that people talk about ranges. We've banned the word normal. So this is my kid's book. It's called Own Your Period, and it's in lots of libraries. I'm not selling. But we talk about average ranges. So we talk about, for kids, an average menstrual cycle range is oh God, I don't want to get it wrong, 21 to 45 days for a kid who's starting their periods, but as an adult, 21 to 35 is average. And, you know, when I was growing up, we had the 14 days for this half, 14 days for this half, ovulation bang in the middle. And that's not true. The first part of the cycle isn't the first half. But what's normal for you is your normal. So giving people ranges of averages is really helpful. And that sort of builds on knowing when to get help. So also asking for sentence starters has been really practical for kids. They've in author talks I've done with the Girls' Day School Trust, the feedback they received was they were particularly excited to give their pupils sort of conversation starting sentences to talk to doctors and parents and teachers and friends about menstrual health. And that's an interactive thing that's very easy to do. It's just literally sentences on a web page and maybe a couple of cartoons. Representation is important, though. The other thing that I did ask about the resource was, for the bite-sized one, could all of the people not look like sort of a cookie cutter cutout silhouette of a lady? Yeah. Different body shapes and sizes, sort of like gender representation and race and ethnicity and just and ability. There's lots of visibly disabled people in my book, even though the book's not about disability. So yeah, those are just little tidbits that you can sprinkle in.
It seems there's consensus that the NHS resources probably need a bit of a revamp.
A really quick thing just to add, really quickly. I wanted to mention that some of us have worked with the NHS England and we've created content with them, and what makes it difficult sometimes is time. So I can film a video right now, edit it, post it, boom, done. Yeah. If I do it through the NHS, I have to show them the script, we have to edit the script together, then film the video, make sure that all the content is fine, is anything copyrighted, this and that. It makes it so complicated. We, as colleagues, including Nighat, we created a video for bowel screening, cervical screening, and breast cancer screening, right? We did a multilingual video, and we had multiple GPs and other healthcare professionals invite and encourage women and people to do their screening. Shared it with the NHS. We can't show this because we need to go through these hoops. There's so many hoops to jump through. And that video, it's in 25 different languages. This is so simple, like that's what complicates things.
I just had, we did one, for breast cancer and cervical screening as well.
That's what I said.
Oh, sorry.
I said bowel surgery. We did it for all three, and we had so many amazing who volunteered their time. This is the other issue. Most of the times they want us to create videos without any, what's the word? Remuneration. And that's a problem because when we work as doctors, we do get paid. So a lot of the things that we're doing is good, it's goodwill, free will, but this is again what makes it a bit difficult for us because sometimes it just doesn't feel like it's level. Some people will get paid, others won't, and I think that that definitely plays a part. So
do you want to finish off with my final bit about whether we've got a particularly British problem with talking about these things or not?
Yeah, I think my Canadian accent has maybe been clocked. I don't have an awesome British one. But yeah, I think what we've seen with Medical Her Stories, so we've had over 300 volunteers over the past 5 years across 12 different countries. So everyone from the UK to Dubai, Japan, Sudan, everywhere sort of bringing their own experiences. And we've been really shocked to see that these issues aren't an NHS issue, they're not a Canadian Medicare issue. Like sexism, shame, and stigma are so deeply embedded in healthcare as a concept, as an institution, as a historical legacy, and the threads are eerily similar of sort of the feeling dismissed. So I think looking for good examples, we can also sort of expand our circles there.
Are there any countries that do it better?
No. We're all going through puberty at the same time. So I'm from the US, but if people want to pretend I'm Canadian, apparently that's a compliment. That's the right way around. So hello, neighbor. And sorry, but I'm from Sheffield in my post-American life. So yeah, you spend.
Yorkshire, yeah. I'm just a bit further
Brilliant.
north.
So yeah, I mean, every country has a north, right? So in New York, there was good sex education in New York and New Jersey, but terrible period education. And that was actually the way I noticed the difference. But I do say, like, as a globe, we are all finding ourselves in this same position and sharing knowledge. The Society for Menstrual Cycle Research is a brilliant global resource that brings people together at conferences that, we wish more people would receive funding from their governments to attend because the global scholarship helps move the conversation on. And it's not just researchers, it's researchers, clinicians, artists, activists. It's an amazing resource, and you're not alone. And I do think sometimes, though, it helps to, if you're already experiencing stigma because some other aspect of your identity is stigmatized or marginalized, it can sometimes be easier to have an objective view of something that people don't want to mention. And you feel more comfortable mentioning unmentionables, at least I do. But maybe that's what you're seeing as is it Britishness? I don't think it is. And also, I'm from somewhere else, and I feel comfortable talking about this and challenging this here. So
that's brilliant. Thank you so much.
Can I just add to that?
Yeah,
I just think as well, with the Britishness thing, periods have been sat under like hygiene for so long, and if you think about how we behave with anyone going to the toilet, even sneezing can be uncomfortable. Like if you've got an itch in your throat and you want to cough and you're on a train, like we just don't like to upset other people. So, and we've put periods in that kind of place, and we are trying really hard to move it into something else, but we then put it under sex, which also makes people then go, body and health. I think people aren't offended by that. I'm not offended by body and health. I think even just choosing the terminology of this is body and health education and not sex and not hygiene really helps us just to say what it is, and without, and I wish we weren't so British in those ways, but also it's we're being considerate. We're like, it's mannerism, it's good manners, I suppose, is what we're trying to do. So just finding where to sit it is body and health education or information is much easier than hygiene and sex.
Brilliant.
Can I just add, on the Britishness note, every single time you go to a dinner party, though, and you start talking about periods, it's the most favourite topic that everybody will always have. So we're not that British.
People are just waiting for an invitation.
Yes. Yeah. It's like, let me to talk about this.
I can guarantee that you two would get like lots of questions, Aziza and Nighat, about and doctors just generally. As soon as you say you're a doctor, you're going to get loads of questions. Similar if you say you're an MP. Thanks, Kim. Thanks, Kim. I fall into the opposite category of Kim, and I probably overshare. So, and long may that continue. But there is something that is said about what's happening in social media and in traditional media is around misinformation. I'm going to ask Kerry and Aziza this question. What do you think the NHS and the government could be doing more of to tackle misinformation? And in some cases, I'm going to say it's disinformation because it's deliberate. Kerry and then Aziza.
I would really like to see, like we have a verified badge for people who like prove who they are. Some kind of badge system which gives somebody a stamp of approval to be able to give health advice, information, knowledge. So, the doctors that are posting on social media, if their badge is a red badge instead of a blue one, that shows that they've proved their qualifications and their stance to be able to share that knowledge. Just two things I've spotted just 2 weeks ago and challenged, and then got lots of really nasty comments because I challenged it. There was two girls in a gym filming a beautiful video of them working out in the gym gear, and one complains about her stomach bloating and a large stomach area, and the other one says it's actually not your belly, it's your uterus. That is your uterus, and which it wasn't her uterus. And so I said, just misinformation. I love that you're being really supportive, but it's really important that young people don't think that's their uterus. Lots of people wanted to argue with me about that, and also knowing that they're not arguing with me because they think it's not true. They're arguing with me because people then click on their account. So the online world is not really about informing, it's rage baiting. It's like, I'm going to say something just that I don't even think is true, just to cause arguments and ideas. So for me, as much as I love social media, love the videos, it's not a place that I'm going to use to resource my education in the classroom, because it's not being verified and it's not being kind of given the tick box of this is safe information. And if you do deliver RSHE, a chunk of that is online safety and data sharing and verifying good sources. So I can't promote watch this YouTuber and say this in another classroom saying watch who you watch, make sure it's from a good source, because it conflicts the two. So working out give us that resource that's clarified and verified.
Thanks, Kerry. Aziza.
And actually, there is something like that in YouTube. So YouTube created this YouTube health shelf where in order for you to be on this health shelf as a healthcare professional, you have to prove that you have a license, medical license, you're with the GMC, and also that you've had a certain number of views. So, you have to jump a few hurdles to get onto it. And then you get the badge and the tick, which I guess is a good thing, but in some ways, some people, sadly, there is still the negative narrative associated with doctors. Some people just do not trust doctors, so they see the tick and they're like, well, I don't want to listen to them. They just want to sell me vaccines or all, the negative narratives that is associated. But YouTube has tried to do that. I definitely agree that there should be some sort of verification to ensure that the content is scientific evidence-based. Because yes, you absolutely have a lot of people, rodeos out there selling supplements especially. And when we talk about women's health, we know that research is only 1% to 2%, right? So we don't, for a lot of the conditions, we don't know why they happen, and also we don't have cures. So women are left vulnerable and they're being exploited. And so yes, all of this misinformation, they're being sold these supplements or all of these remedies and being told that they're cures. There needs to be repercussions. There needs to be sanctions and repercussions for individuals who are selling things that are not factual and actually that may be dangerous in the long term, or even if it's not necessarily dangerous, you're taking a lot of people's money because they're so desperate. So there should be something to say that it's not right. And a lot of the times, as I say, if you share the most absurd thing, that's the one that seems to be pushed. We need to try, if there's any way at all for content like ours that are being shadow banned to be reversed, because those are the information that is life-saving, that can make a difference, and that could be the difference between life and death for someone, really.
Thank you very much. I'm going to hand over to Alex now. I am told that we are moving quite quickly through that debate, so we may end up with 4 votes at some stage as well. Okay.
Thank you. This is absolutely fascinating. So I'm just in the interest of time, I'm just going to ask different questions to one person only. So to start, Nighat, can I just ask you, do you think that girls and young women using period trackers, you mentioned, as a group we've mentioned period trackers already, do you think they have enough information to effectively choose a period tracker?
So no, I don't think that's the case at the moment, and a lot of it is awareness out there, and also I always worry about data protection and the selling of your data to individuals as well, and tech companies, femtech, have a huge responsibility. So there's a mistrust already, because now young girls have become aware that tracking online or on a tracker means that they might be sold products that they don't want. And that monetization really concerns me. So I've moved away from some of the big period trackers, apart from ones I would say are linked with charities, which I know are not for profit. That's why I think that it needs to sit on the NHS. How I feel about data protection in the NHS is a whole other conversation. But I think it needs to sit somewhere where there's that level of trust, that level of security, and fundamentally the safety for young girls and women and my patients with their data.
Yeah, thank you. And to follow on from that, would you share concerns that the femtech sector is not drawing sufficiently enough on racially diverse data, and does that then have an impact on exacerbating health inequalities, for instance?
Yeah, so I would say more than inequalities, equity, health equity is massively disparaging at the moment in the NHS. And I see that time and time again with my health collective that I'm working with. We've mapped grassroots organisations. And I'm not just talking about black and white, I'm talking about those with a hearing impairment, disabilities, those that have a visual impairment, traveller communities, Tori mentioned refugee communities, poverty as well, that plays a huge part, access to online information. And so we know that health equity is actually the biggest barrier for actually appropriate care when it comes to women's health already in the NHS. So when it comes to femtech, those that have the means and the financial means to buy that tech, yes, their data will be pulled, and so it's skewed towards that. AI is already skewed towards, dare I say it, the white middle class narrative, and I would say a north-south divide as well. So if you live in the north of the country, you will be you'll find there's a huge disparity compared to if you're London-centric. So that plays a huge part in regards to what is accessible when it comes to femtech, and that concerns me because the barriers are getting worse and more entrenched, but the distance between those that can afford it and those that can't, the worried well and those that actually genuinely are sick, is getting wider and wider in the NHS.
Can I add to that, because I know it's just something we spoke about in preparation for this meeting. I meet lots of young people, particularly black and ethnic minority young women, that do not have access to phones and computers. Their parents are much stricter with allowing them a mobile phone at the ages 11, 12, 13, 14, so they're not engaging on this online news information, femtech stuff. But one of the things where I always look for a solution, it's like, I know the problem, so what's the solution? Every young person, when they go to a secondary school, they get a homework diary. I'm sure we had them when you went to school, where they have a timetable in, you write your own work in them, get signed. Putting things like these period trackers inside those, so they're not costing families, they're normalised, every student gets one every year. It's old-fashioned paper-based, but we sometimes need that, especially when we're looking at people who haven't got data, Wi-Fi.
And I get those diaries in my surgery.
Yeah, so just simple things like adding a couple of pages to that would reach lots and lots of young people.
Yeah, that's really interesting. Thank you. Sometimes the old-fashioned analog way is the best way to go. Thank you. Tori, I wonder if I can come to you at this point and ask about the potential for young people using femtech trackers as contraception. Is that then obviously potentially leading to unwanted pregnancies? Is that something that you've noticed? Is this happening? And if so, what can we do about it?
Yeah. I think that question fits really nicely into some of the things we've been seeing around sort of misinformation or concerns around contraception around young people. So Medical Her Story, in addition to all the work that we do, we also partner a lot with researchers, and we've been developing a project looking at young people's health, sexual health 16 to 18. And in doing this, what we've been hearing a lot about is a lot of concern around I don't know if I want to say traditional or maybe more medical forms of contraception, specifically the birth control pill. Yeah. A lot of people worrying that if they go to the doctor and that if the birth control pill is given as first-line treatment, that's a form of dismissal. A lot of concern around, I think a lot of misinformation around, if you've been on the birth control pill for X long, you don't know yourself, you don't even know if you like your partner, you have to go off it and find yourself. And I think we have to be really concerned about how those narratives fit in within a larger push of conservatism, of sort of traditional housewives, of reproductive rights, maybe encouraging people to take on more reproductive roles without reproductive rights. So I think where those sort of femtech apps come in is addressing that gap. Others on the panel might have more expertise on me about how reliable those are, but I think the more interesting question is almost around why are they showing up and why are people turning to them, that we can be thinking about and addressing.
Alex, can you just come in on that one?
Yeah, I was going to. So in terms of these femtech, first of all, the best way to not get pregnant is to not have sex, which isn't realistic, obviously. And the natural contraception method is something that's been used for a long time before contraception pills and the hormonal contraceptives came into play and made such a massive difference in a lot of our lives. There's a lot of misinformation, a lot of disinformation, as you say, around hormones. In fact, there's hormonophobia at the moment. Loads of people just do not want to take it, whether it's HRT or the contraceptive pill. They've been demonized. In order for people to use those sort of systems, they really need to understand their periods and they need to understand their cycles. In order for them to understand their cycles, they need to have great education from the early days. Because if you ask a question, and I do a school education, I asked the girls, what's the typical number of days for your, so I said to them, your menstrual cycle typically lasts between 2 to 7 days. And guess what their response was? Yes. And I was like, no, because your menstrual cycle is your whole cycle. So they didn't even have that background knowledge. And these were girls between the ages of 15 to 17. And if they're turning to use the natural contraceptive methods, how? If they don't quite understand what exactly the menstrual cycle is, what happens, what are the changes that happens at each part, and then how then you can reliably utilize that. So these things can be helpful, but they're so strict and rigid. And even me as a 38-year-old woman, I wouldn't rely on that myself, because it takes a lot. You really have to be regimental to use those methods and for them to be accurate. Nothing is 100%. And there's something called perfect use, when nobody's perfect, and perfect use is 98%. And then you have the typical use, which is more realistic, and that's, 70-odd%. So that's what I have to say about that.
Thank you. Thank you. That's interesting. Tori, if I could just come back to you for my last question briefly. What do you think the role of the NHS and or government should be in the femtech space, so that we can start to ensure efficacy, data privacy, and also this inclusive approach, this health equity approach?
I think echoing what's been said about health equity is super important. I think technology often has the ability to sort of re-entrench and reascribe inequities within the technology. So, the reverse care law, that, the people most in need of care are the least likely to get it. Things like that, I think we see within that. I think also it's interesting, because Medical Her Story, I don't know for what reason, but we often get put on a lot of, femtech panels. And I think it's quite interesting because the work that we do technically is online, right? Like the stories are online, social media is online, our events, you can watch them all on YouTube, it's all accessible. But I think the way that sometimes femtech companies talk about these issues as, billion-dollar opportunity instead of a billion-dollar problem is something the NHS, I think, should be aware of and sort of cognizant about. And I think leading by example. So we've heard some great examples today about, charities that are doing amazing work that the NHS could be adopting. We've talked to about, NHS websites, and I don't think the NHS needs to be the expert in storytelling, but I know that on every NHS page there's an other links resource at the bottom. I think creating pathways there that make it more easy and accessible for companies or organizations that aren't for profit to be raising awareness, destigmatizing, having access to that, like we've been saying, would be maybe some easy wins, but there's a lot of bureaucracy there. So a complex problem.
I was just going to say, I think it'd be really amazing that if we do have femtech companies who come and give evidence about how they're going to do it, because the role of AI is going to become wider and wider, and the ownership on women and girls and boys understanding their bodies is going to get more and more in the palm of their hand as we go forward. And so where does that responsibility lie at the moment? We're saying it's the individual and the parent, if it's a young person, or if it's an older person, then it lies with them. And I feel like femtech companies do have a role to play, and it's a good role. I've seen some great outcomes, even in clinical practices, where a patient's come in and she's realised that actually her symptoms that she was experiencing, because she's tracking so well, could be signs of PCOS. And she had no idea until she started tracking. So I think that it would be great to get the femtech companies to work collaboratively.
Interesting, thank you. Thank you, Alex. Nadia.
Thank you. Firstly, I just wanted to say thank you so much. I think it's been particularly healing hearing Asian and Black women in particular talking about this stuff. I feel like it undoes a lot of generational stigma, which obviously exists across all communities. But I'm 29 and I still haven't had my smear test, which I was obviously meant to have 4 years ago because I'm absolutely terrified. And I'm going to book my smear test after this.
We are more than happy to guide you through it.
Yes, thank you. Actually, yeah, it's okay.
Yeah, that's absolutely. No, absolutely. Because firstly, you're not in the minority with that. Please don't feel that there's shame or stigma, but you are definitely not in the minority. And yeah, we've got you.
We're on my 30 before 30 list, so that's how I know it's going to get done. Firstly, to Chala, you mentioned previously that the Department for Education's period product scheme for state schools and FE colleges has improved. Does it ensure that appropriate and sufficient period products are available? And is that the case for for girls and young people who experience very heavy menstrual bleeding?
Yes and no. I want to say that the scheme review and update 2 years ago was excellent, and it was conducted by outstanding people at the DFE who did roundtables. They were very thorough. They tracked their changes. They did a lot of work around reviewing what had happened before and what didn't work. Some of our young people said they wanted nighttime pads, and that wasn't part of the scheme. This was immediately changed. And the next time I spoke to one of the researchers there, she said that this was immediately taken up. Where the scheme falls down is that the people in schools, and this is genuinely going back to Shirley Prendergast's research from 1994, she said that there was no joining up of provision of education and stuff in schools. Now we know this also should be in non-state schools and other settings as well. That's one of the other flaws, but the people who are in charge of procurement don't necessarily know enough about periods. The maybe cleaners and caretakers haven't had training. What we always say is a period positive school should be one where the lollipop lady, the head teacher, the chair of governors, anybody could address a teachable moment around periods, whether that's a leak or a question or providing the right product. So now that change has been made, young people who experience heavy bleeding are more provided for, but period underwear wasn't covered on the scheme in the early days, and that's still difficult to access depending on the brand, depending on how you do your procurement, because the reusable product companies aren't as well established, or are small companies that have been bought out by multinationals who have different agendas. And holistic menstruation education that goes from staff to pupil to person at the council who's in charge of helping lead the procurement, it has to be really, really good, and it isn't really, really good. So for all the wonderful roundtables and all the excellent updates, they're not being met halfway yet, and that's something that needs to happen. So I think the future of education should be tied into the provision of products in that they link to each other, and the product provision scheme must refer back to a curriculum in a cross-curricular way. It should all tie into the tracking of cycles as well. So if it is some pages in a planner, or if it is how to, like a computer's lesson on how to use apps safely based on protecting your personal data, or if it's a maths lesson teaching them mode, median, and mean, and averages by looking at an average menstrual cycle, or if it's media studies teaching, persuasive language in advertising, not using a car ad, because what year 6 pupil can drive a car, but what year 6 pupil might get their period. All of these things have to be in place to support the free product scheme, because products are providing a short-term immediate need for those experiencing period poverty, but it's also a poverty of knowledge and of confidence and of access, and those things are essential.
Thank you so much. And Carrie, I think you and Chella touched on this previously, but we've heard of schools locking toilets, which obviously prevents girls from accessing period products. Is that an issue that, how common do you think that is? Is it something that you're aware of happening on a large scale? And do you think we need stronger DFE guidance to stop that from happening?
I mean, I recognise that there's got to be some kind of regulation, like pupils can't just be leaving classroom as and when, for any different reasons, but we just need to have a human approach. I worked in, last week I worked in 3 schools, 46 perimenopausal on my period, and I had to follow the school day like any other pupil. So I leave my house at 7:30 in the morning, I arrive at school at 8:30, I'm straight into 2 lessons back to back. So I haven't been to my bathroom since I left home that morning. So break time, it's crucial I get to a bathroom alongside 1,500 other students who have break at the same time. How many toilets? There isn't enough for everybody, so you have to make a choice. Do you really need to go? Are you in the queue? Are you gonna? This is happening. It's just not set up correctly, and they do try schools with staggered break times, toilet passes. There's lots of different things that they've done. There's no really easy fix. It's not. We can't just have anyone can go to the bathroom at any time, but we do need to recognise that women are on the periods, some of those women are having heavy periods where if you are on a heavy period in a classroom which you've been in for 2 to 3 hours, you will start to panic. Are you flooding? Is this on your seat? Is this on your clothes? You are then not learning. You are not concentrating on information. And so in them cases, and I'd like to think that most teachers I work with are very lovely, and if a young person said, "Miss, I really need to go," "Sir, I really need to go," they would be allowed to go. There's just a relationship between when you know your students asking because they really need to. So I think most of the time that happens, and I think reassuring schools that that's okay and that their policy should reflect that we are people with bodies and we might need the toilet sometimes and it's not on their timetable.
I mean, Kerry, you're reflecting what, as an NHS GP, every 15 to 10 minutes we get a patient, so you cannot just go to the toilet. So I remember I put in a coil in a patient, I stood up. I have a coil myself. I'd put a coil into a patient, but I have PCOS, so I never know when I'm going to sort of flood through my underwear. And lo and behold, my scrubs I had gone through and bled through. My patient was more worried about me, even though I had just sort of sorted her out. Went upstairs to get some, look for any, as it always says, look for like period products. There was nothing in our GP surgery. So had to then use toilet paper in my surgery, and then when I got a lunch break, try and head into the village to try and buy some period products. But we at Wellbeing of Women have worked very closely with grassroots organisations, and we're trying to move away from period poverty being a term. Our grassroots organisations find that very demeaning, or menstrual poverty, because period poverty says that actually to have access to period products there's a level of privilege that you need to have. What they have constantly said to us is better to use things like period equity, because not everybody needs the same tampon, the right flow. Some need heavier flow, some need light flow. The London School of Economics have actually said that the most sought after item at all food banks, and as we know with the cost of living crisis, the food bank access is getting more and more in demand. In fact, there's something this morning, I think, about that, which shows that the most sought after item is actually period products before food. So that just shows that there's, shows two things there. One is that the access to period products is getting harder and harder. The cost of it, the pink tax plays a role as well. So if we could have free period products, that would be, I would love you forever if you did that. And secondly, I think that people don't think of it to buy, to put into the trolleys as well when it comes to food banks, because you think of food, but actually period products are just as important. So they go very, very quickly, and they're the most sought after item.
Can I just quickly, because I do have another question that I was going to come back to Nighat.
I'm so sorry. I need to bravely disagree about not letting kids out at all times. I work with about 6 different period organisations that are youth-led, and the young people are absolutely desperate to be able to go to the toilet whenever they want. And I trained to teach in 1999, and I've over the years seen a sort of slow and worrying corporatization of primary and secondary education, and academization, which has led to academy chains choosing zero tolerance policies where behavior and toilet access are inextricably linked. And this is a sign that we are not living cyclically. And I need to be the radical who's not in the classroom every day anymore and not a doctor, and say we need to treat ourselves more humanely as a society, and we must consider a blanket toilet access policy as a national education policy recommendation, because we shouldn't be put in the positions where we're all fighting for the loo or holding it in, or our own coils falling out as somebody's is going in, or whatever, not to be extreme, but we must consider this, because young people across a number of different organizations have said this is the youth-led view. And so it may be inconvenient for teachers, but we simply can't do this, and we should be treating doctors more humanely as well.
Thank you, Cello.
Thank you.
Nadia, did you want to go on to the next question?
Please do feel free to add to the previous question, but a further question to Aziza and Nighat. Are there circumstances in which young women, particularly those who experience very heavy bleeding, can get period products free on the NHS with a prescription? And would you support legislation to provide some or all women with access to free period products?
Yeah, I mean, first of all, I just wanted to say that there definitely needs to be some sort of rule against allowing brands to charge £1 per one period product. So when you're really desperate and you go to the bathrooms and they have them in the stalls and you're desperate and you don't even have coins, because I don't carry cash. £1 for one pad or one tampon, that should not be allowed. That shouldn't be legal. And also certain establishments, you go to a hotel, they don't have period products in hotels, the ones that I've been to anyways, even the poshest hotels, they then...
Needle and thread.
No, they have everything. They have shower caps, they have toothbrushes, you know, but they will not have period products. Does that make any sense when more than 51% of the population will menstruate at some point? But in terms of heavy periods, the first thing that you need to do, and I'm always going back to education, and this is why we run our platforms, many people don't even know what a heavy period consists of. So I'm just going to say it now in case anyone's watching. So a heavy period is if you are having to change your period products every hour, double up on period products, if you're having to put a towel on your bedsheet because you know you're going to leak through at night, if you're bleeding so much that you cannot go to school or do your day-to-day activities, you know, those are not... You said not to say normal, but that's not something that you should just put up with. If you're having heavy periods to the point that you're becoming anemic because you're losing so much blood, and so you're having symptoms of shortness of breath, chest pain, dizziness, difficulty just going up and down the stairs, dizziness, then that's not something that you should put up with. But there are so many women who think that that is normal, and this is because they don't have the education, and also it's passed down intergenerationally. So I'm a black woman. I'm 2 to 3 times more likely to have fibroids, and actually I do have a fibroid. Luckily, my fibroid doesn't mean that I have heavy periods, but that runs in the family. And I've been to schools where a young girl came to me, and I told them what is something that you shouldn't be putting up with. And she said, oh, but my mom said that's normal and that runs in our family. And then we've had patients who, for instance, their daughters, because they're like, oh, I can't let my daughter suffer like me, have endometriosis. And then they're like, oh, maybe I do. And then they get checked and they have endometriosis all that time. So yes, I absolutely agree that we should definitely put something in place. Period products for all. It doesn't need to be prescribed. Why don't we just give it to everybody? Because we know this is something typically that 51% of the population will have an experience at some point. I don't know that there are, there are prescriptions. One of the issues is nothing all over the UK seems to be standardized. It really depends on who knows what's available, where they're located, and that privilege. So there's a lot of work that needs to be done in that area.
So in regards to prescription being given by a GP for period products, I'm aware, as far as I'm aware, definitely in my practice, that's not something that we do. But in regards to managing heavy periods, we still have education for colleagues to do. So we use hemoglobin for women, but hemoglobin is not the best marker. Actually, you need to look at iron stores, which is ferritin. But the ferritin ranges so much, so that could be 15 to 150. And menstruating a woman and girl, so if you're bleeding every month, then actually you're told if it's 15, it's normal. It's not normal. I've now started equating it to women and girls, saying your ferritin needs to be between 30 or 70 and above at least, to make sure that you're getting the replenishment of the stores, which means that a lot of women are misdiagnosed for their iron deficiency anemia as it stands because of the lab ranges that we have, and also the generic products that we give for iron supplementation are not tolerated. So iron tablets can make you feel constipated, you could get bloating, you can get black stool, which means compliance isn't great, which means that if you have an underlying problem, which means you have heavy periods, on top of that you're using sort of lots and lots of products, which is costing you, it means that we're seeing more women and girls ending up in A&E needing blood transfusion. And the latest data that's coming out recently from my colleagues is showing us that the NHS is spending up to £13 million managing iron deficiency anemia for menstruating women, which is a preventable cost if we just managed looking at iron stores, blood tests, and heavy menstrual periods in the NHS. And that could be easily done. Now, in October 2025, a month ago, we did update the NICE guidelines to manage iron deficiency anemia for menstruating women and girls, to say, look at ferritin in particular. Because at the moment, the way that the ferritin levels are done is that we equate men in that data. Men don't bleed out of their penis every month. So we need, well, if they did, we'd have a different conversation.
But free. Period products would probably be
thank
free.
You.
Yeah.
Thank you.
Thanks, Nadia. Sorry, I dropped my chair hat there and just went for it. Kevin, I'm handing over to you.
Thank you, Chair. Sort of moving on to RSE and health education and the curriculum in particular. Kerry, what's your assessment of the latest updates to the RSHE curriculum on menstrual health?
I mean, it's very small. There's not much detail. It says to teach it, and that's pretty much that's it. Teach it. It's in there. So there's not enough of what to teach when. So then it's not standardised then in every school across the country. It's up to each individual RSHE teacher to go and find out, well, what actually do we need to teach? And if you look at any of the workbooks which are currently used in education through schools, it's teaching 28-day cycle, the parts of the body, often not including the outside of the body. It will just be the uterus, the fallopian tube, and the vagina. Sometimes not even the cervix is mentioned. So there isn't like a minimum standard of what that actually means. What I also see, which is a positive, is that it's taught much younger, because we have lots of girls who start the periods in primary school. But then you teach it age appropriately for a 7, 8, 9-year-old. That's not the same education that a 13, 14, 15-year-old would require. So what I see is we get a 1-hour lesson in primary school for primary school children, and that's all very much a reassuring, like puberty, this will happen, you can ask us any questions. It's a lovely lesson. Most schools are doing a fantastic job. And then we get it touched upon in biology in year 7, and a lot of schools are going, well, that's our puberty education, period education done, because science cover that, and they're stretched and there's not enough time to do everything, so that can tick that off, and then that's it. That's period education. So if you're now 14, 15, you've started your periods, you've had your periods for a few years, where do you now ask the questions that you're old enough, mature enough, have some lived experience that you now want to ask, and that's not there. I teach year 9s, year 10s, and Know Your Body workshops, quite popular, that schools pay for me to go in and deliver. And even just this week, I think I've worked with 1,000 young people over the last 2 weeks. Them young people did not know that they bled from a different part of their body from where they pee from. These were year 10 students, year 10. Very mature, wonderful, great questions, amazing young people who did not know that information at 15. They have had the RSHE since 2020. So they've had it for 5 years and they still didn't know. So something's not hitting. And I would say it's because it lacks detail. So we are allowing each individual school. I would 100% ask for, I said guided learning hours. That's because I'm teaching higher education, further education. Schools come back to me and said there's another way of giving a subject specific hours. I would put that to RSHE so that it's not 20 minutes in tutorial time. Some schools delivering it 1 hour a week for year 7s, 8 and 9, nothing for year 10s and 11s, because the focus is massive, nothing for college students. So I would, if I could, minimum standard of hours and more detail, but like be clear, this is what period education is, and it's not 28 days, it's not.
I've always wondered, Kerry, in school, whether it's the right person delivering the education as well. Is the teacher educated about all the anatomy and the biology?
So I think personally, young people said they want period education. RSHE is in schools because young people wanted it, so we listened and it's there. So I do think schools is the starting point for that, because young people said, with our friends in our schools, they're used to learning in that space. That does come with all teachers then being educated. I've mentioned this before. Can we not go and newly qualified teacher training, and teacher training, module, RSHE, every single qualified teacher will then come through having been trained in RSHA. So we've dealt with what's coming up, and then we've just got the now to deal with, which I think is then a smaller task of local authorities. Raising confidence, I think that's all them teachers need. They're equipped enough, experienced enough to go and devise a lesson. They just need knowing that what they're saying is right, is not going to be shunned upon. They're not going to see a backlash for it. So I think that's a space. But I also advocate massively. I've been around quite a while doing sex education in schools, and I worked under SRB funding back in the early 2000s, and we were given really lovely budgets to do health and wellbeing work with young people in partnerships with local authorities in schools. And so my job back then, I would go in a school alongside teachers, deliver workshops, but then say to young people, and if you need any more information, we're at the health and wellbeing drop-in. They could come once a fortnight on a Tuesday. There'd be myself and a school nurse or a sexual health nurse for 3 hours. And so we've got a universal offer of education, is the basics, but then we've got a community local space where young people can get, well, actually, you said something about this, I need some more information. And then from there, we can refer the ones that need the referral. It worked. It was not extremely expensive. And I think it needs to have both a classroom and community approach answer, not just teachers. There's just not enough space to keep adding and keep doing more.
And if it's going to be built into teacher training, there's two things really from that. I mean, how much extra would that be adding on to the teacher training course to really build this in? And then what do we do about the older cohort of teachers that have already been trained? How do we get retraining into the system?
So, thinking back to when I went to university, like, it's self-directed learning, a lot of what we do. So it doesn't have to take that much time if we put it on the initial teacher training. We could put a module on there, tasking, people to know the guidance. That's the first thing. Do a micro teach of a lesson from the guidance, plan a resource. There's lots of different things that could be done, and a lot of that would involve just reading, I suppose, but giving them a book list of relevant materials, because they're in that space of learning and absorbing that information anyway to become an educator. So it's not far away from asking them to do something else on top of an already existing job. And I think with our teachers now, I'm not a fan of online modules. I don't know if you've done them yourself. I just have a cup of tea and click through, and I don't really absorb the information. I'm a fan of face-to-face training. I think you can change. I've done lots of training in schools, 200 people from the caretaker to teachers. In 20 minutes, you can change their mindset. That's all we need to do to teachers. They're teachers. They know how to plan a lesson, they know what to do. We just need to change their passion and understanding of why they should do it, and I think that's all we need. And money, I should say that. They want more money for funding for the training if they've got to do this, because right now it's the RSHE guidance is there, the extra lessons, but no money to deliver it.
Taylor in, how much money do we think that is? I mean, roughly.
Well, it depends how you want to do it. Do you want to give it to each individual school, or do you want to create a space, maybe with the NHS, where all that stuff's there and then they can access it, if that makes sense? Like this, rather than...
Because some of the feedback that I've had when I've done videos of how to explain to a Gen Alpha about what a period is or what a vulva looks like, I get lots of teachers going, that's actually helped me lesson plan, and thank you for the education, because now I know how to speak about it. So I always worry about how much the teachers are learning, because when I go into schools, and Aziza goes into schools as well, we get boys and girls together in one room, and 100% all the time the teacher at the end would say, I've learned so much from you.
And I think it's just a different vibe as well. So I've recently gone to, I've recently gone to a school, and the biggest thing for them was, a doctor is like this, and I can approach them, and they're fun, and they explain things. So I feel like definitely we need the PHSC, and actually it was a PHSC teacher who reached out to me. But it gave the students that confidence to know that doctors aren't that scary, they're not that bad, they have the knowledge, and actually now I know things. And then the teachers learned from the way that I've taught them. And it now means that hopefully, it changes that narrative and they have the confidence to learn. And what some of the feedback that they said was, for instance, the teacher learned more about adenomyosis from that talk. So I think there's definitely room to add doctors and the PHSC teachers.
I'm sure as GPs and doctors you should be recharging and can have been changed anyway for that training. Chayla?
So we have solutions. And so I agree with everything. And in 2018, I was invited to be on a panel by the APPG for Women's Health, and I was here, and I was really nervous. It was my first time here, and I presented the first draft of a curriculum model that includes, by key stage, topics that are drawn from skills, knowledge, and understanding that match other types of skills, knowledge, and understanding for that key stage. So learning about the water cycle in year 3, learning about the digestive system in year 4 means you can absolutely learn about the reproductive system in year 4. It's the same type of learning. I mentioned maths, I mentioned computing, I mentioned graphics. All of this comes together to show that this curriculum model exists. Every other school subject didn't plop from the ether, but unfortunately menstrual literacy has to, because the history of cultural stigma meant that it didn't develop naturally, like teaching modern foreign languages or history or maths. The program of study exists. It's even called the Period Positive National Curriculum, because I thought I could sneak it in by calling it that, but it deserves to be there. And the way we roll it out is the way Healthy Schools operates, or the way the Gatsby benchmarks help schools to sort of chronicle their delivery of careers education. So just like every teacher is a teacher of literacy, or a teacher of numeracy, or a teacher of IT, every teacher is a teacher of menstruation. And we did a piece of work on this in 2023 called Menstrual Literacy for All. We did a pilot with 2 schools and an LGBT youth charity and a youth homelessness charity. And it wasn't just a design sprint creating lessons, it was bigger. It was surveys with adults, and we've since replicated that survey with young people this year. Would you want to learn about menstruation from any teacher? And the answers were a resounding yes. Do you have enough menstruation education? Resounding no. Would it be okay to learn more about periods and get more training to teachers? 314 teachers, I think 78% said absolutely. In the 90s% said we didn't have enough or none at all. And there is an enormous appetite for this. The Period Positive Award helps you track it the way the Healthy Schools Award does. The curriculum model works like the Gatsby benchmarks. And yes, I say give me an hour and I'll have the meeting, out of the palm of my hand, like being free, being open. 20 minutes is amazing, and I need to learn from you, Carrie. This is incredible. But I completely agree. Maybe in 2018 people weren't ready for this, but this is legit and real and in black and white and on a video. And so on behalf of the young people that want this, and the teachers that are willing to do this, and the parents that are really supportive and keen, and the homeschool kids who are absolutely chiming in the same way as everybody working in the formal education sector, like, let's do this. You can have it. It's free. It's open access. That's the point. And it goes outward. It sort of ripples. So one school becomes a gold standard school only if they're working with other schools and community services in their sector, and other cities support each other, and nationally it could work. It would probably cost about as much as Healthy Schools, which it's not a lot a year, but probably we should ask for more. So a blank check, please. Because it's invaluable, really. I mean, menstruation education is fundamental. Everybody had a room that was a womb. That's what I always say. Boys should be in the room. People who never had a period and never will should be in the room, whether they're a doctor or not, or have daughters or not. It doesn't matter. We all lived inside a uterus. That was our first apartment, if you like. And we all have a right to understand how they work, and a responsibility to make sure that everybody can use theirs the way they wish to.
Thank you.
Just one more thing then, really, probably back to you, Kerry, in the first instance. Obviously there have been calls for education to address racial equality around menstrual education. Yeah. I mean, what are your thoughts on that, and are we meeting that yet or not?
No, absolutely not. And I think we don't even, I'm a white cisgender woman, so even me answering this question, but I don't know enough what's said in your household and what was said to you, and where do I get that information, and so that I'm equipped when I'm designing my lessons, that and meeting the diverse classrooms that are now teaching. So no, we don't. But again, when you're telling a school to teach period education, if you then give them what that means, and here's the resources, and here's the links and the websites that will help you. If you're in a diverse school, you've got that there, you can use it. And if you're not, you've got other access to other, your faith school, you've got access to faith materials. I just think it's about, they need access to not accredited is not the word, but schools are very worried about, because of the media backlash of teaching anything to do with sex, relationships, gender, they're scared. But if you say, you can use this, we okay this, then they will use it.
Do other people on the panel think that's the right approach, or maybe we need to do something else or more?
Cultural competency training is really important, and you don't quite understand things unless you've experienced it before. It makes such a massive difference knowing. So we mentioned where people are from. I'm actually originally from Sierra Leone. I was born and raised in Saudi Arabia, and then I came to the UK, so I got used to the system in the UK. However, it's understanding what happens at home and how things are viewed, how they say different, how they approach different topics. Because some students may be struggling, but because at home they just don't talk about periods at all, you need to have cultural competency training. And if we're able to have that widespread throughout the UK, because the UK is multi-ethnic, it would make a massive difference.
And one of the places where that's been really great has been grassroots organisations. So there's Sisters, which is run by Neelam, Birmingham. They work with South Asian communities, black communities and trans communities as well, and it's trying to look at the language barrier for period. So in Punjabi we don't have a word for period, but it's become a acceptable term, because the Punjabi word is actually kapde, which harks back to the Punjabi days in India and Pakistan where you'd use rags. So being on your period is I'm on my rags. So young girls, 15, 16-year-olds, hate using that. And obviously now they're bilingual, so like myself, I would always, even though I speak Punjabi, when I'm speaking to my mum, I'll say a period. She'll squint and be like, no, it's kapde. So I think that sort of cultural, and that comes within communities. And again, we've worked with other communities, so Inherent Birth, they're also looking at the lexicon that's used around periods as well. And it's different dialects and the way that they say it. So Bangladeshi communities, Sri Lankan communities. And this is why the collective is trying to do a lot of educational work. And we feed into schools because our charity members go into schools and teach in their local locality.
You know, in British Sign Language, it's the same, actually, just from a language point of view. The term for a period is different for different people. And I've spoken to older British deaf people who use BSL signs that are more secretive and private looking. And young people or people using home signs would use something more expressive. Even in the US, the sign's very close to the face, where it would be like, it almost looks like the sign for bashful. So that kind of leads into disability inclusion. There's not a lot of awareness about teaching around sensory needs for neurodivergent menstruators, because different products feel different to different people, and also people with limb differences or less fine motor skills might not be able to use menstrual products in the way that the little leaflet explains it. It's not, how you contort yourself. You can't if you don't have the dexterity to maybe insert a tampon or menstrual cup, but there are styles that are designed to be used one-handed, but most people don't know about them. So it's in terms of cultural literacy, as part of the 4 types of menstrual literacy, is absolutely geographical culture and like queer culture, disabled culture, all of these aspects of people's lives that sort of maybe remain unseen in wider menstrual conversations coming out is really valuable.
Which reminds me, actually, because the use of period products such as tampons or moon cups are really frowned upon, because it's going to break your hymen, so you're not a virgin anymore, which is steeped in stigma, taboo, patriarchy. But again, in that cultural competency at schools, some girls will find that is definitely not an option. So if you're only talking about tampons or moon cups in that lesson, it's not talking to that cultural group who, for them, so we work with a lot with Roma Gypsy families who say girls cannot use period products. Again, some Muslim groups as well, where the hymen is like their way of showing that the girl is a virgin for arranged marriages, and that is their cultural practice. which I think that it's very hard for schools to keep on top of that, and it only comes from educating and from those groups, which we're hoping to do, because we think that that should be part of the women's health strategy, actually.
Yeah. And I was just going to say, a lot of the puberty and period education now that in the schools that I work in, they are showing all types of products. There's period pants, there's moon cups, there's disc, the discs that are now out. There's lots of different things, and lots of schools have got that already embedded, rather than just...
We teach that through a dance, you know, it goes internal, external, disposable, reusable.
And
the
it's
fastest way to teach it.
This bit is fascinating, and I know that we could talk about it for a long time, and we should, but we've also, I'm conscious of votes, and I don't want to finish before we have actually finished. So thank you, Kevin. I'm going to hand over to Christine now.
Thank you very much. Can I thank you all? It has been absolutely fascinating, and in some ways reassuring. But I wonder if I could ask Nighat and Aziza, our 2024 report found dismissive attitudes, gaps in GPs' awareness and knowledge about menstrual and reproductive health. Present company accepted, obviously. Do you think things are starting to improve? For example, do all GPs receive adequate training on women's menstrual and reproductive health?
I start with the fact that GPs are generalists. Not all GPs are going to have an education which is steeped in women's health. We all then are asked to choose a speciality, and then you go into an area of specialism. So that was started, I believe, under Tony Blair, where you could be what's known as a gypsy, a GP with a specialist interest. Unfortunately, that training sort of fell away to the wayside, so it came upon self-directed learning for GPs to go and do what area that they like to go and do that, because as the funding fell away, then if you are already working, paying for so many other courses, etc., which are very expensive, then it might mean that you don't prioritise women's health, although that is 50% of your population. The educational programme and the RCGP will say that they're trying our best. We do have now a women's health education, which is led by our colleague Dr Nighat, who is doing some incredible work in that area, which both of us are working with the Royal College in order to improve that, because it is part of self-directed learning. People don't have time to do modules. And a lot of us health content creators are learning from each other on social media platforms, but I think even GPs will say that it's better, and it needs to get better. Sorry.
But not just GPs. I think we need to look at the whole system, because it's also within secondary care, and we cannot. I'm glad that paper came out. I mean, loads of people were really surprised, but it is true. Medical misogyny exists, and we get a lot of messages. So I get messages from, I had no idea that these symptoms were abnormal, and I need to get checked, to I've been to my doctor so many times and I've been told actually there's nothing wrong with me, dismissals, and so on and so forth. So there needs to be education all around patient population, but also within the GP practice. And what Nighat was just saying, that technically they'll say that women's health is mandatory in the training, but actually having an hour on menopause is not enough training. You're going to forget. And we do have, all of us have specialisms in what we're best at. So not everybody will be a specialist.
Just very, very quick point. Women's health doesn't fit into a neat specialism, because if you've got cardiovascular health, in fact, I want my cardiologist to understand about hormones and menstrual cycle, because that will affect cardiovascular health. I also want my endocrinology colleagues to understand about PCOS, but that doesn't really sit anywhere, because secondary care colleagues in gynecology will want to be involved if there's a procedure or treatment or fertility issue. We're more than just our fertility beings. There's more aspects to that. So what it does is it comes back into general practice. And I think that that's where the biggest disjoint is because women don't fall into a neat specialism. And so I would say it's sort of like the desert at the moment when it comes to women's health, because no one's really taken ownership apart from general practice, I would say, or individuals who have a specialist interest in that area.
It involves the whole body. Mental health as well is a big thing that a lot of people talk about. Everything is intertwined, so everyone should be a women's health specialist technically.
That would be a very good idea.
That's brilliant.
Thank you very much.
Thank you, Christine. Before we moved on, I just want to our last section, which is Rachel. I just wanted to ask Kerry a quick question that related to the previous section. I'm quite honest with my 5-year-old when she asks me why I'm bleeding, and I tell her, not everything. And I also say, like, this has to stay, you can only chat about this inside the house, because not everybody will want to know at this stage at 5. What do you say, and how would you advise schools that are seeing pushback from parents for learning, even if it is age appropriate, around menstruation?
Around menstruation
and around anything to do with young girls' health and their bodies.
I mean, I don't think menstruation should fit under sex education and then be something that can be withdrawn from. I would argue that is not sex education. It's body education, it's health education, and every person needs to know that information. What I would say to schools who've got parental backlash is, first of all, to understand. I mean, even me doing this job all my life, my mum would go to the shop and put pads in a brown paper bag. That's like, so even she was like embarrassed about this stuff. So understanding where they're coming from and why that shame exists and why they're apprehensive and frightened about their children being taught. And I think a lot of the good practice is the community work, when this is not just delivered by a school but delivered in the community. So you know, your groups in the morning, what parents go to, the singing groups, if everybody's kind of on the same page, if they sing songs about body parts, if it's mentioned not just in the classroom in school but everywhere else as well. I also go back to very old school me, and I do love books as well, so probably why. When I had my children, who are 28 and 27 and 18 now, I got a book when I was pregnant. It was conception to birth. Like, the NHS give everybody who had a baby one of these, and it became my like go-to. We didn't have the internet then. And then when the baby was born, you get 1 0 to 5, and then 5 it's like, go on, crack on, figure it out for yourself. I would love to see one for primary school parents that has that information. So it has the puberty, it has the period education in there. And it's all right saying it's online, but there's so much online. Let's just have it in, that's their book, it's them. Health physicists could give it to them. And then again, for secondary school, you could have another one which would then include the pornography, harmful sexual material, drugs, alcohol, like so much stuff. Very simply done, and I loved that, and I valued that information, and it felt very trusted and didn't feel like I had to search for it. So something like that I think would help reassure parents and teachers.
Can I just say, mum to mum, that's really saddened me that you said to your 5-year-old, keep that in the house, because that's self-censorship.
It is.
Because I'm a mum to a 7-year-old son, and my 5-year-old, he was 5 at the time, so exactly the same, found one of my unused tampons in the bathroom and thought it was a sweet wrapper. So I spoke to him about it in the appropriate language and said, you know, mummy has a bleed, she's not in pain, it's nothing to be worried about. And I use this because, you know, women and mummy also has a bleed as well. And in Ramadan, that's why you don't see me fasting, because I'm actually on my period at the time. So I don't know how much he took in, he understood that. But he did share that at school with his friends. And so one of the mums spoke to me about it. And she said, actually, I'm really grateful, thank you, because that's made my conversation with my daughter a lot easier. And I think maybe it shouldn't be the responsibility of always educators, but as parents, let's just stop there and just say, this is something that we're going to, and so for us to, I don't know what I'm trying to say, but...
No, I do understand, and like it does feel like self-censorship, but at that stage it didn't feel like, because she will just talk.
No, but
I know it's the right thing, but
as mums and dads, I would just, you know, removed from me as a doctor, I would just say that is life-saving information that you've probably, you know, shared, and actually it's just part of life, because bleeding is part of life. We wouldn't be here without a period.
Yeah. But I hear what you're saying as well, in argument, because I taught my daughter vulva from the very beginning. She went to nursery and she said vulva to her friends, and then the nursery teachers were really taken aback, and they came to me and said, oh, do you know what, the parents are going to be really upset if she uses that language. We've taught them private parts. Similarly, when she's been in school, and this is when she was 6 years old, she was telling her friends about something to do with vulva, and then her friends also said, no, it's private parts, not right. And then the teachers eventually said, oh, it's okay, we'll teach them in year 2. when they're 7 that the word is vulva. So there needs to be a balance where we normalize it for parents.
Yeah, for normal.
So then there's not that shame and stigma. So you don't feel that you have to because you're worried that she might. But it's good because we should all know this, you know.
We're like holding
on a
space
personal
for
level,
ourselves.
I just feel like possibly there's enough to be angry at their MPs about already, without adding my
without
child
that being in the paper.
Without that being it. But I do take your point. And
if
at
it
some
takes a
stage,
village
yeah,
to raise
it
a
does
child.
take a village, and I do feel that I think Kerry's point around once we have that kind of community education, actually it's not an issue. But yeah, no, I will take it back and I will reflect on it. And,
it's risky,
and I'm going to be
isn't
honest, you've probably already talked about it.
There are those of us, I'm sorry, I'm butting in and you're the chair. My mom's going to be very angry with me because she's watching. But we all have to hold each other and support each other in space. We are the risk takers and the outliers now. And based on 10 years ago, 20 years ago, when I started, there's many more of us now. And we are working toward this. And there are going to be difficult conversations, but isn't it wonderful that you could like respectfully challenge it and support each other?
In the bud.
The next that will make it normal.
So, you know, this is
I just join
your
the butting
time.
in for a moment because I think the thing that you've all got in common, which is progress and is good, is that regardless of the terms you're talking, you are talking to your children about it, which a previous generation wouldn't have done at all.
Well, we probably wouldn't have an entire committee session about this. But I am going to hand over to Rachel for the last section of our panel. Thank you.
I'll try and make this quick because you've all actually already given us some ideas of answers that we could suggest for the next women's health strategy. But what I'd like to do is just ask you all for one thing that you would like to see included in the renewed women's health strategy and for it to be a sort of specific, measurable thing. So I'll come to you first, Tori.
I might take us back to where we started this session with today. I would love to see more talk around the vulva. I think that's something that's really missing from the women's health strategy. It talks about vulval cancer, of course, but it doesn't talk about any vulval health conditions like vulvodynia, recurrent thrush, lichen sclerosis, vaginismus, and the whole range of host of issues there that are also really important when we're talking about menstrual health. So if you have a vulva that's already in pain, trying to use menstrual products, whether they are pads or tampons, is going to be more difficult. Blood changes in hormone levels we know can affect these conditions. So I think we definitely need to be thinking more about these intersections of different health conditions, using the word more. And then also, as some of us has been mentioning today, thinking too about it more broadly. So thinking too about the trans and gender diverse people that also have vulvas or that also are menstruating, and how they're accessing the same services that are maybe branded under women's health. So just being inclusive of that as we go forward.
Thank you. Aziza.
So being in the social media space, I'm very cognizant of the fact that there's loads of misinformation and disinformation. What I would love to see in the women's health strategy is something to provide either, I don't know, some sort of guidelines or even repercussions for people who are selling fad information and perpetuating that negative narrative. I'd like there to be something in place to ensure that the education that is being provided through social media is reputable, scientific, and evidence-based, and there's something called PIFTIC, which is Patient Information Forum, which again is another accreditation to show that your content is credible. But it would be good that if there was something in place to stop the misinformation and making that measurable, because YouTube, and this is an actual stat, 6.8 billion views in the UK alone in 2024 were on health conditions. People are using social media for their health information, so it needs to be accurate.
Thank you. Chala.
So the Women's Health Strategy that came out in 2022 said that within 10 years they wanted comprehensive menstruation education for boys and girls in all schools. And that's too long. It's been 3 years. We're still waiting. We got to do it now. So we want you to adopt a national cross-curricular menstrual literacy program, which follows the 3 recommendations from the young people I worked with in 2013. Tell us everything, don't leave anyone out, show us who we can trust. We want the whole span. It's each of these events in our lives is not siloed. We are people who, have menarche, a first period, and become postmenopausal one day. And there are many ups and downs in terms of reproductive health and menstrual knowledge along the way that get missed or that don't get joined up. Include more positives and more powerfuls. What I mean is talk about ovulation, talk about the positive feelings at different stages of the cycle, talk about cyclical well-being. Please fund a larger pilot for Period Positive. I trademarked the name so that nobody could steal it from like a menstrual product company and use it as their slogan or hashtag. It's meant to be inclusive, educational, and sort of by the people, for the people. Because I was tired of how I learned from some menstrual product companies, free leaflets and a video, and then I wanted to buy that brand for the rest of my life, even when I couldn't afford it. Nobody needs to learn that way. It's weird. It's weird that schools use these resources or ever did. No other school subjects taught that way. But we want to adopt a way of evaluating this. How do you measure who gets free products, why, how, and who pays for them? How do we measure how well schools are doing and what they need to do better? And why can't we fund everybody to learn this all collectively together, whether it's in teacher training programs, whether it's in medical schools, whether it's people who are already in the sector working, getting extra training. Take it off my hands. I want to do comedy shows about dinosaurs and maybe go back to my PhD. But please fund something, take a risk and do something, because the willingness is there and I want to see it happen.
Thank you, Nighat.
The one thing I want from the Women's Health Strategy is equity in healthcare for the whole life cycle. It was part of it, but it was almost a wishy-washy. So we took it upon ourselves, myself and Professor Dame Leslie Regan. We came up with the Health Collective. These are grassroots organisations who are doing work for free. We can learn from them. We know what works. For too long, we'd admired the problem. We now to make sure that we deliver on the asks from these grassroots organisations who work in different spans, and so they know exactly how to provide equity in healthcare, and that is something that I'd be more than happy to help deliver as part of the Women's Health Strategy.
Thank you. And Kerry?
I think similar to that, it's really looking at the youth and community and how you can embed the women's health issues, the women's health answers, responses in the community, and not just within health, not just within schools, but everywhere. Girls' work, women's groups, all of that kind of stuff.
Thank you. It's been an absolute pleasure, and I never thought I'd say that about talking about the vulva for the whole afternoon. And before you came in, we were discussing our medical misogyny report and how it might lead to medical misogyny the musical. So perhaps it's vulva the musical that is what we really want to see.
Rewind it. There is a song.
That is a good way to end.
That
is the first time that we have ever ended a committee session with a song, and we did a whole one on music and the misogyny within the music industry, and we didn't hear any songs. So that is
there is a dance. It takes you 2 seconds, and not to this is not Greek, but if you do
and dancing.
Internal, external, disposable, reusable, and if it's little kids, inside your body, outside your body, throw it away, use it again.
Oh.
And that is the quickest way. If you don't know disc, if you can't remember cup, if you don't want to name a particular brand, it comes from Modern Foreign Languages education, linking vocabulary words to dance moves. It's a mambo and a conga line. I won't put pressure on you to conga line out of the room today. Maybe the next generation will.
Next time.
Thank you so much. This brings possibly one of my favourite ever sessions to a close. Order.